This episode of PediaCast CME is brought to you by Adolescent Medicine at Nationwide Children's Hospital. And welcome once again to PediaCast CME. We are a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. It's episode 109. We're calling this one Supporting Teens with Smoking Cessation. I want to welcome all of you to the program. So we have an important topic for you today as we explore support for teenagers who are ready to quit nicotine, which is not an easy thing to do. And it really does require lots of support from parents, but also from their medical providers. Many of us, however, may not feel equipped to support teens through this process, which is something we hope to remedy today with this episode. We're going to explore the evolution of nicotine use among adolescents and young adults. Cigarette use is down, which is terrific, but e-cigarette or vaping use is way up, which is not so great. So we're going to explore the latest prevention, diagnosis, and treatment strategies for nicotine use disorder in teenagers, along with assessing readiness to quit, evidence for pharmacologic interventions, harm reduction, and practical tips for pediatric healthcare providers. We have a trio of guests joining us in the studio to discuss the topic. Dr. Kelsey Schmuhl is a patient care pharmacist at Nationwide Children's Hospital, as is Dr. Jen Berg, and Dr. Amy J.Z. is an adolescent medicine fellow at Nationwide Children's. Don't forget, after listening to this episode, be sure to claim your Category 1 credit. It's absolutely free. Just head over to the show notes for this episode at PediaCastCME.org. It's episode 109. And you'll find a link to the post-test there in the show notes. Follow that link to Cloud CME, click on the Materials tab, and then take and pass the post-test, and the free Category 1 credit is yours. And we do offer credit to many pediatric professionals, not just physicians, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by all of those professional organizations, it's likely we offer the credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also want to remind you the information presented in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get our expert panel settled into the studio, and then we will be back to talk about supporting teens with smoking cessation. It's coming up right after this. Dr. Kelsey Schmuhl is a patient care pharmacist with Adolescent Medicine at Nationwide Children's Hospital and an assistant professor of clinical pharmacy at The Ohio State University College of Pharmacy. Dr. Amy J.Z. is an adolescent medicine fellow at Nationwide Children's, and Dr. Jen Berg is also a patient care pharmacist at our hospital. All three have a passion for supporting teenagers in their quest to quit smoking. That's what they're here to talk about, smoking cessation. But before we dive into our topic, let's offer a warm PediaCast CME welcome to our guests, Dr. Kelsey Schmuhl, Dr. Amy J.Z., and Dr. Jen Berg. Thank you all for visiting the studio today.
Thank you for having me.
Yeah, I'm really excited to get to be here.
Great to be here.
Yeah, we are really excited to have all of you here as well. You're all busy people, and it's great when we can find a time when everybody's schedules fall in line and we can record these things. Kelsey, I wanted to start with you. How has adolescent nicotine use changed over time? I'm thinking that cigarettes aren't really the focus as much as vaping these days. Is that the case?
You are absolutely right. So among adolescents, we know that combustible cigarette use remains low. Where we've really seen a dramatic increase is in e-cigarette or vape use among this age group. In our National Youth Tobacco Survey, which is conducted annually, our most recent data show that we have seen a decrease in e-cigarette use. From 2023 to 2024, we saw a decrease from 2.1 million to about 1.6 million e-cigarette users among middle and high schoolers. And now, while we're really happy about that decrease, that's still a lot of people, and that's a lot of young people using substances, and we know that that has consequences later in life. So we really believe that this should be a focus of adolescent care and somewhere where we can intervene. So I hope that after today, people are feeling more confident asking about e-cigarette use and also treating e-cigarette use in their practices. And we know that among people who vape or use e-cigarettes, the highest age group are people 12 to 25. E-cigarette use is really highest among our young people, whereas combustible cigarette use is more likely to occur in adults 26 and over.
The e-cigarettes, there's so many different form factors for those. And so providers and also for parents, you may want some knowledge in terms of what these things look like, especially if you do not use them yourself. The CDC does have a e-cigarette products visual dictionary, and we're going to put a link to that in the show notes so folks can find that easily. And then there's also the concern with the vapes that they can have other things in them, like THC, for example. Are we seeing teenagers also using combination products like that?
We are, and we've seen that vaping devices or e-cigarette devices can actually be modified to use other substances as well. That visual dictionary is a really nice resource for people to learn more about how e-cigarettes have evolved over time, how people are modifying them, and how they're used. I think that's a great resource to check out. I use it myself a lot when I'm learning about new things. But yeah, most of our adolescents today are using e-cigarettes, like you mentioned, and mostly disposable products. We've seen kind of an evolution of these vaping devices. When I first got started in this work, probably around 2018, 2019, it was mostly those cartridge-based devices where you could buy a device and you buy cartridges separate and then you utilize the cartridge but the same kind of overall device. Now we're seeing more disposable products, meaning they're pre-filled. They come in many different sizes and shapes. They have a wide range of not only nicotine concentration, but also the amount of puffs or uses you can get out of that device. I will say that most young people that I've interacted with, we're seeing disposable products are more common. I think this likely stems from a ban that the FDA put in back around 2020 that really banned the use of those cartridge-based systems. But there was a loophole that allowed for disposable products to still be used. So we saw a lot of young people switch over to these disposable devices. And as you may guess, our young people are more attracted to the flavored devices as well. I think that's another big attraction for youth. They come in all kinds of different flavors that teenagers see as fun and they like the flavor. Much different than how a lot of people feel about the smell and taste of cigarettes. The most common flavors that we really see are the fruit flavors, there's candy flavors, and there's mint flavors. Those are probably the most popular that we're seeing. And another thing to know about e-cigarettes is that they use what's called nicotine salts, which have a lower pH, meaning more acidic, whereas cigarettes are free-base nicotine, which means they're more basic. Now, what that does is it allows people to use higher doses or higher amounts of nicotine, and they have less irritation in their throat. So we're seeing that that's another reason we really have to pay attention, because even though there might be this kind of perceived image of safety, a lot of folks are using more nicotine than they even intend to, unintentionally, just because they can, and they don't have those consequences associated with it.
Yeah. It's interesting. Just to be clear, so there was legislation to stem the use of the cartridges, which led to more of the disposable kind, and then those end up in the landfill. So, we've not really fixed the problem. All that we did was create another problem.
Yes, and it's hard to keep up, Dr. Mike. It's, things are constantly evolving, and it is really hard to keep up with what folks are doing. But yes, it seems like we're always one step behind sometimes.
Yeah.
But there's also been similar kind of legislation. I'll give you another example, as you've probably heard of nicotine pouches increasing in use. So while nicotine pouch use actually remains quite low among young people, we are hearing about them more as they also are introducing things like flavors to them. But when those first came out, since they are called a synthetic nicotine, meaning the nicotine is made in the lab, they technically didn't fall under control of the FDA because the FDA can only control tobacco-related products. And that nicotine didn't stem directly from the tobacco leaf. So it's really interesting. That has since been remedied, and the FDA can now regulate non-tobacco nicotine products. But it is really interesting how we kind of always had to play catch up.
Yeah. And I think folks don't understand that the concentration in the vapes is so much higher than it is with the cigarettes. And so that you can really become addicted very easily because of just how easily then that chemical is transferred into the body through the lungs and in higher amounts. Amy, why is this important? Like, why are we talking about this today? And in particular on a CME podcast for providers?
Yeah, I think, there's really two parts to this question. I think, why are we talking about nicotine use in general? But I think I'm going to start with just like why we should be talking about substance use in teenagers and adolescents. We know that the adolescent brain is still developing, right? Everyone knows that. We talk about that all the time. It's, developing into the mid-20s, but it's also this huge time of growth and plasticity. And then it's about the areas of the brain that are growing that's so important, right? It's your prefrontal cortex that's still learning to regulate, that executive functioning, that decision-making, the planning, the impulse control. And then also the limbic system is actively maturing during this time. And that's the place that really is like your motivation and reward center. So what we think about when we think about addiction. And there's really two mechanisms by which the brain is kind of growing during this time that can be really affected. One is myelination. So those nerve fibers getting enhanced myelination, so allowing for more effective signaling of all of the brain signals. And then synaptic pruning is also happening. So while you're having this huge period of growth, then the brain starts pruning these areas back that aren't being used. So there's this kind of saying we like to use it or lose it. So the areas that you're not using are going to get pruned back, but the areas you are using are just going to be heightened. And so at this time, the brain is super sensitive to novel experiences. So if you start using a substance earlier and then using it over and over again, those are the areas of the brain that are going to continue to grow and aren't going to get pruned back. And this is true for any substance that gets used during this time. When we think about nicotine specifically, adolescents are really even more vulnerable to that because of a few unique aspects. So in the limbic system itself, that reward pathway, there's actually an increased number and activity of the nicotine receptors in that area. And then on top of that, there's an increase in nicotine-induced dopamine release, which again is that reward pathway. So that puts these teenagers at even higher risk for becoming dependent on nicotine. And I think there's some really interesting data out there in animal studies that actually look at like the acute behavioral effects of nicotine. And what they found is that when you compare an adolescent to an adult, you find that adolescents are actually more sensitive to the rewarding effects, so the positive rewarding effects. They actually have blunted withdrawal symptoms, where an adult, they might have worse withdrawal symptoms, and they can actually tolerate higher doses without aversion, whereas in adults, those higher amounts are actually going to cause aversion. So they have this like unique increased positive short-term effects and a decrease in these negative short-term effects, which again, like puts them at higher risk to develop dependence. So this is like the key time frame in which we can prevent this from happening. And so I think sometimes people are like, it's an all or nothing, but really, I think all of us on this podcast would agree that a harm reduction approach is even appropriate, right? So any delay in use for a teen is going to be a positive because you're going to get them through this part of brain development that is so critical, because we know almost 90% of adult smokers start before the age of 18. So if we can delay that onset, we might delay the dependence that develops from it.
And in addition to the brain effects, just the addiction, does that make it more likely that you'll continue to use nicotine throughout your life? And then as adults, we really see a lot of cardiovascular, heart attack, stroke kind of risks, and that you could potentially prevent if you stop smoking or stop having nicotine ingestion in adolescence.
Exactly. Correct. Yeah. All of the like long-term, even longer-term negative effects that you think of when you think of nicotine use, if we can just prevent an adolescent from even starting use, right, you might prevent all of those downstream effects later on in life. And it's so much harder to get them to quit once they've started than just to prevent them from starting in the beginning.
Yeah, absolutely. So we want to prevent nicotine use, but sometimes it's already started and we can get to the point that we would actually call it a nicotine use disorder. What exactly is that then, and how is it diagnosed?
Yeah, that's a great question. And I think actually kind of goes back to Dr. Schmuhl's point of that, there's actually not a nicotine use disorder in the DSM-5. It's tobacco use disorder because, again, that's kind of what it used to be, that it was combustible cigarettes were kind of the main source of nicotine. Nowadays, I would still say we would call it a nicotine use disorder because that's the main component in it. But like most substance use disorders, it's really defined by a problematic pattern use that leads to some sort of clinical impairment or distress. And then there's kind of a whole list of criteria, and you have to meet 2 of them in the last 12 months. I think it's really hard to remember all of the criteria. I think there's like 11 of them. So when I think about it, I like to break it up kind of into parts. And so the first 4 criteria really are around behaviors of use. So are adolescents having to use more? Are they using it over longer periods than they intended? Is there this persistent desire to use and they are unable to cut back? Are they spending a lot of time in activities that they need to like obtain a vape or find somebody who they can, use it off of? And then cravings and urges. So those are kind of like the behaviors that make up this disorder. And then the kind of 5 through 9 criteria are really around the consequences of that use. So are they failing to kind of fulfill major obligations? And really, when we think about teens, we think about like, is school starting to be impacted? Are they having continued use despite maybe having recurring problems? So are they getting into arguments with parents? Are they still using at school despite maybe an expulsion or a suspension? They're giving up activities because of use, so maybe no longer playing sports because of it. Are they using it in situations that maybe are hazardous? And then even though they maybe have some knowledge that it's causing physical or psychological problems, they're still using it on top of it. And then the last set of kind of areas is really around dependence. So that's tolerance and withdrawal. So again, needing to use more and more nicotine to get the same effect, that would be tolerance, and then withdrawal, those effects you see when you stop using. So they have to have only 2 of those. Usually they're coming to us because they're already getting in trouble at school, or maybe they've tried to quit and they're having some withdrawal effects. So usually they're meeting these criteria pretty quickly.
Yeah, as clinicians, when we see teenagers, they're probably not vaping or using cigarettes in the exam room, hopefully not. So how can we kind of get an idea of who we need to talk to a little bit more about this and to try to assess if nicotine dependence is occurring? Are there some signs that would give us a clue that this is someone we need to spend a bit more time with?
Yeah, that's a great question. And I know you joke about patients probably not smoking in the room. That's true. I have had patients pull out their vapes when I ask them, like, what are you vaping? And they're like, oh, let me show you. And I'm like, I don't know if I really want to see it, but I can now at least get a better idea. So yeah, I think there's several things that we can look at when we think about like dependence. It really kind of, again, encompasses that tolerance piece of it. So if you've been maybe seeing a patient over several visits, are they telling you they're having to use more and more? They are using more and more nicotine is one way to look at that. And then the other is those withdrawal symptoms, which really can come in 2 flavors. It can be physical withdrawal symptoms that they're having. So asking them about, are they having some sleep issues? Are they having like an increased appetite when they're trying to cut back? Are they having restlessness? And then also psychological and behavioral issues. And sometimes these can be even more bothersome than the physical symptoms. So a lot of like irritability or anger. They may have like a really depressed or anxious mood that may even be worse than somebody who already has anxiety or depression, or a lot of difficulty concentrating as well. And I think these withdrawal symptoms can really interfere with successful cessation, which is why it's so important for us to be able to really figure out what someone's dependence level is.
And then how do we go about doing that? So Jen, is there a tool to sort of assess where folks are in terms of nicotine dependence?
Yes, there are a lot of tools available online. Some of the older ones are more geared toward the traditional combustible cigarette use, but a lot of newer questionnaires are more specific toward e-cig use. So one example of that would be the Penn State Electronic Cigarette Dependence Index, which is 10 questions. And if answered truthfully can kind of help gauge how high of dependence a teen might have on nicotine. And when these conversations are happening in clinic or in the hospital, we really need to be direct and ask for specifics. So the tools do a great job of kind of quantifying and getting patients to answer how soon are you using, how frequently are you using, but really important to make sure we get the numbers. So how many cigarettes are you going through a day, or kind of, as we've mentioned with this focus on e-cig use, how many puffs are you using a day? What specific device are you using? Kelsey alluded to the fact that there are many devices. So we need to know what device, how frequently they're switching out cartridges or going through devices, how long does it last? And then again, we collect this information, but then sometimes we have to do some math and Googling in the background because there's so many devices. And e-cig devices range from having anywhere from 300 puffs per device to 25,000 puffs per device. So as you can imagine, a kid that's going through a 300 puff device in a week has a different level of dependence than a kid going through a 25,000 puff device in a week. And again, even once we've collected that information, the conversion isn't exact. There's one study that suggests that one Juul pod is equivalent to one pack of cigarettes. So we can kind of backtrack and do some math to say, oh, you're using this many puffs. That comes out to like X amount of packs of cigarettes. But again, the math is not perfect on that. And then in addition to doing these questionnaires and having these conversations, I always think it's a good idea to kind of ask about some of the like social and economic factors surrounding use, because we know kids are using these age-restricted substances. So how are you getting access to nicotine products? How are you affording it? Are there any like access barriers? And what does that look like? Because some kids might just be using puffs in their friend's car on the way to school, whereas some kids have a whole side hustle of like purchasing and reselling pods on the side. So kind of having an idea of how integrated their use is to their everyday life will also help us gauge, in addition to their level of dependence, like what quitting might look like for them.
And we'll put a link to the Penn State Nicotine Dependence Index, the questionnaire, in the show notes so folks can find that easily over at PediaCastCME.org. This is episode 109, but that's something that at least it does take into account the vaping aspect of it, as opposed to just solely looking at combustible nicotine-based cigarettes. So here's, I think, where the rubber really meets the road. So we may find a teenager that we've identified as using nicotine, and perhaps we've even, gone through the survey and we are concerned that they have nicotine dependence. Amy, how do we then get teens to quit? Like, they want to do this, and we know it's harmful, but they probably don't see it as harmful at their age and with the condition of their brain and where it is in development. And they may even have parents who vape or smoke cigarettes. And so there's a role model in the house saying, hey, this is okay. So how do you, try to convince them that this is something that they should stop? And then how do you know when they're actually ready to do that?
Yeah, this question I could talk about for hours. It's a lot of obviously what we do in our clinic, and Dr. Schmuhl does, and Dr. Berg does as well. I think it starts with, talking about behavior change models, and I'll get to that in a second. But I really like to start visits just by like setting the stage. Because like you said, some patients may have families that are also vaping. And at the same time, sometimes we have patients that get brought in because a parent's concerned about their vaping or their substance use, and the child doesn't know why they're there. There have been a lot of times, especially in our substance use clinic, where a patient is brought in and has no idea. So I like to kind of set the stage, like, tell me why you're here today. Tell me a little bit about what your idea is. I also like to make sure that they know, as we're talking about substance use, that if they're not able to make a change, or if they do and they return to use, that's not going to like impact, the therapeutic relationship I have with them. I'm always there. When it comes to substance use disorders, there's this cycle that happens, and sometimes use occurs again, and that's okay. And then the other thing I think that's really important for both patients and families to know is that, we really have to meet them where they are. Because if they feel like they're not being heard, or if they feel like we're just telling them what to do, or their parents telling them what to do, they're probably not going to come back or they're not going to engage with us. So I like to kind of set the stage when it comes to that this may be talking about harm reduction. How can we just decrease use without completely stopping? But when it comes to actually assessing kind of where a patient is at in terms of like their readiness to quit, I think probably the most commonly used behavior change model is stages of change. It's 6 different stages, and it kind of looks at what's the patient's readiness to change. So the first 2 are really that pre-contemplative stage and the contemplative stage, where in the pre-contemplative stage, patients have really no idea that this is causing harm. They don't understand the risks of harm at all. And the goal in that stage is really just to increase a teen's awareness that there is a problem. In the contemplative stage, they may have heard that it's a problem. They may kind of understand that it's a problem. They may be considering change. And the goal there is really to help kind of tip the balance between pros and cons of their use. And so I often like asking questions like, what do you like about vaping? I think people have never asked them that because they're always like, don't do it, don't do it, don't do it. I think trying to figure out why do they enjoy it? Are they using it to treat some sort of underlying anxiety? Do they use it because all their friends are using it? And then also asking them, are there any downsides, right? And trying to figure out what would happen if they didn't vape or didn't buy a new one. And I think it's really in these first 2 stages where we can do a lot of change talk and a lot of, motivational interviewing, which is a big buzzword nowadays. But kind of, I think using scales can be a really helpful tool. Sometimes I think clinicians don't even know where to start. Like, what if they tell me they're using, like Jen said, a pot a week or something, and you're like, well, now what do I even do? I think, again, trying to understand where they're at. So how important is it for you to cut down on your vaping? And on a scale of 1 to 10, where are you at? And that scale of 1 to 10 kind of helps give like a very objective number that the next time you follow up with them, you can ask, well, where are we at now? Has that scale moved at all? And then the last 3 stages of change are really when they've decided to make that change. So they're kind of in this determination or preparation phase, the action phase where they're actively making it, and then the maintenance where they've made it, and now you're just continuing that. And once they hit where they've decided to make a change, doing some of that motivational interviewing can actually be a little counterproductive because they've already decided to make the change. So turning now your focus onto the reasons that they have decided to make a change, how confident are they in their abilities, and what barriers may there be to actually being able to implement that change, and then working with them on, okay, is there anything I can do? Is there anything your parent can do to help you overcome those barriers now that we've already decided that we want to make that change? And then the last and final stage is really that relapse or return to use. And again, reminding patients like this happens. It's not, a negative. It's just now we kind of have to renew that process of contemplation, reminding them, the reasons they had to change previously, the positive aspects that came from when they weren't using in the past, and just kind of starting that cycle over again. But I think figuring out where somebody is along this spectrum helps you tailor your conversation, because somebody who's in a pre-contemplative stage where they haven't even decided their use is problem sum, if you just jump all the way to like, let's set some goals to quit, you're not going to get there. And it's going to, again, be kind of counterproductive. So
we have a lot of pediatric providers who listen to this podcast. And I think this also probably holds true for anti-vax messaging. Like if you go full bore into someone who really has their mind set that vaccines are harmful, this is like the mirror. This is like the exact opposite. But the same concepts hold true. That you do have to approach it, carefully and sort of assess where they are, and then once they're open to hearing messages, then providing them at that point.
Exactly. And I love this model because it can be used, right? Like we're talking about it from a substance use standpoint, but this behavior change model works for any behaviors, right? So whether it's vaccine hesitancy, whether it's like lifestyle changes that we're trying to work on changing, it can be used, that framework can be used for anything. So I think it's a really great one. And the CDC actually has some really great guidance too, if people need or want some more structure to having that conversation.
Yeah, like based on where they are on
Exactly.
on their own journey. Kelsey, I wanted to ask about medications then to help with smoking cessation. It's nicotine is really like the cravings for nicotine, and then how folks feel before they use and then after they've used it is really huge compared to like even opioids. So that craving can just be very, very intense. And so just to tell someone, hey, it's not good for you, stop. but then not giving them the tools to stop, you're not going to get very far. So what kind of tools do we have in terms of medications to help teens quit smoking or vaping?
Yeah, you're absolutely right, Dr. Mike. When we think about going cold turkey on nicotine, that has a very low success rate among all populations. So it is important that we equip teens with some appropriate tools. Now, I will say before I start talking about medicines, that the studies for these medicines were all done in adults and to people who smoke cigarettes. So we've had to kind of make some adaptations and use our clinical judgment when we're using these in younger people. Now, like I said, none of them are approved for 18 and younger, but we do have some evidence of their use. So I'm going to go through that today. There are 3 FDA-approved medications for smoking cessation. First medication or class of medications is called nicotine replacement therapy. Among nicotine replacement therapy, or NRT, we have patches, we have gum, we have lozenges, and we have a nasal spray. There used to be an inhaler, but that is no longer available. Another thing to note about these is that patches, lozenges, and gum are available over the counter for people 18 and over, and the inhaler is prescription only. The nasal spray, not the inhaler, that's no longer available. But we can still use these in people 18 and under in certain circumstances. Now, none of these are over the counter for people under 18. So if you're going to treat somebody with a medicine for nicotine cessation, you should write a prescription. This also helps with insurance coverages, as these products can be quite expensive if you buy them over the counter. So where do we have the data? American Academy of Pediatrics actually has a guideline out for nicotine replacement therapy, and it kind of tells us when would be an appropriate time to use that. So after you've gone through all of the assessment that we just did and determined that an adolescent or young person is moderate to severely dependent, they consider using nicotine replacement therapy as appropriate. We don't have a lot of efficacy around nicotine replacement in young people, but we do have data that show it's safe. So if I have somebody who's under 18 who presents with moderate to severe nicotine dependence, that's usually my first go-to. Now, there are other medications for nicotine cessation. One is varenicline. That is a prescription only, and it's a pill formulation. And we have bupropion, which is also a pill that's prescription. We do not have the data for those medications as safe and effective in younger people. Although I will say, hot off the press, there is some new evidence coming out, a new study that actually did look at varenicline in people down to 16 years old that show that it may be safe and effective. So, practice might change as we have more evidence coming out around some of those other medications in youth.
A quick question. In terms of the nicotine replacement therapy, I think it's going to be really important for providers out there to recognize that it is okay to prescribe nicotine to kids under the age of 18. Because when you think, it's unlawful for anyone who is under the age of 18 to purchase nicotine over the counter, it's not illegal for them to use it. It's only illegal for them to purchase it. Is that correct?
You're correct. And, in pediatrics, we use things off-label quite a bit. I think there is some stigma around substance use, and maybe people won't want to use things off-label as much. But this is something that we do quite frequently in pediatrics, actually, because there is not as many studies around for pediatric populations with some of these medications. So it is absolutely appropriate to use this off-label if the situation is appropriate for that. With nicotine replacement therapy, we're going to get into some of the specifics here in a minute, but the way it works is that, as the name implies, it's going to replace the nicotine that would be delivered by your vape device or your cigarette. So that means it hits the same receptor in the brain, that nicotinic acetylcholine receptor, and acts as a full agonist. So the more you use, the more the response you're going to get. Okay? So one of the things that's hard about nicotine replacement is that you really have to stop using your other forms of nicotine when you switch over to nicotine replacement. Otherwise, you can get a lot of nicotine in the system and actually have kind of too much and feel sick. A lot of people say if they continue to use their vape or smoking when they're on these products, they often feel nauseous is the biggest symptom. So that can be hard. So that's another way of like meeting somebody where they're at and saying, we have these products available, but are you going to be able to do this? Do we need to work behavioral strategies first to get you down to a lower level of nicotine so they're actually successful when you start nicotine replacement? And I will say, the guidelines will say in people under 18, really the gold standard is behavioral therapy. That's the only thing that's really been studied. And a lot of patients benefit from co-occurring medicines and behavioral therapy. But for nicotine replacement therapy, combination therapy is going to be first line. Dr. Berg is going to talk about that in just a minute. And combination means using a long-acting product like a patch and a short-acting product like gum or a lozenge or nasal spray for in the moment. So you kind of have both on board. You have nicotine being delivered by the patch all day. And then when you have cravings, you would use gum or lozenge kind of in the moment. And you can use that quite frequently throughout the day. So that would be kind of, if you had somebody under 18, you should feel comfortable starting those in that patient with a fairly close follow-up, I would say. Nicotine cessation is really difficult. So when I'm working with somebody, especially early in their treatment, I like to see them, every 1 to 2 weeks to make sure things are going well.
I'm wondering from the family's perspective, I would think that a lot of families would think, well, why don't we just decrease the amount that we use slowly? So in other words, when it was cigarettes, we could say, hey, there's a lot of harmful chemicals in cigarettes. And so switching to nicotine replacement is really your better choice. And, so we cut out the exposure of the carcinogens. But with vaping, there's also chemicals in there, but their effect is not quite as known as for cigarettes. And so it's kind of harder to say, oh, we've got to get you off of the vape pen. And so from a family's point of view, couldn't you just say, well, if I'm doing 10 puffs a day, this week, and then go down to 9 puffs a day for a week, and then 8 puffs a day for a week, could you do something like that? Or do we really see that the nicotine replacement products and getting rid of the vape completely is more efficacious?
It's a good question. And I think the example that you just mentioned, Dr. Mike, if it was a low number of puffs like that, if it was going from 10 to 9 to 8, I think I wouldn't use nicotine replacement because to me, that doesn't indicate a really high level of dependence. And we would just work on behavior change. But oftentimes the more likely situation is somebody has a device with 15,000 puffs in it and they're using, close to 1,000 puffs a day. They might have it with them all the time. And like I said, they're not really getting a lot of those adverse effects like the irritation in the throat and things like that. So they often don't even really realize how much they're using. It's much easier. It doesn't smell. It tastes good, So a lot of my patients can't really quantify how many puffs they're using a day. But when I tell them, okay, what's your device? How many puffs are in it? And how often do you have to buy a new one? It's really eye-opening to them that maybe they're using over 1,000 puffs a day.
See, that's eye-opening to me. I would have thought they're doing 10 a day. That's a lot.
The amount of times that I have told patients using that calculation, which again is a very rough calculation based on fairly old data, that Juul to cigarette pack data, where I have an adolescent coming in who's probably vaping like 2.5 packs of cigarettes a day. Like that's what I can tell them. And they are like, and again, that's probably actually an underestimation given that like the products we have nowadays are actually a lot higher concentration of nicotine. I think that almost sometimes is jarring to them as it is to you and I and on all providers that are out there. But I think, again, being able to quantify that because they're just so used to having it at their bedside. They're just like, I'm basically puffing on it all day. Like I don't have an exact answer for you.
Yeah. You don't have to go outside. You don't have to wait for a break. It's easier to sneak. But to answer your original question about, why can't we just decrease our use? It's almost impossible for somebody to go from that level of use to just decreasing. So it often takes a long time. And, when I'm working with patients, a lot of them, it's the physical dependence as much as the actual vaping. The vape devices are small. I've heard a lot of people say it's like the perfect size for my hand. It's like a fidget toy. I have to have it in my hand. Okay. So working on those behaviors is really important as well. And, kind of unlike cigarettes, I think like they just like the taste. They miss the taste. So it really understanding kind of those motivations that we've talked about is important. And maybe our decreasing use is like, okay, you're not going to take your vape when you drive to the grocery store today. And like very small goals like that. Or if we give you nicotine replacement, maybe you're going to use it in this specific situation just for this week, setting those small goals. I'm going to talk about varenicline or brand name is Chantix in just a moment, but sometimes that can help with people who really struggle with decreasing their use before switching over to nicotine replacement.
Jen, let's talk a little bit about that combination therapy. So the long acting, like with the patch, and then the short acting with gum or lozenges. What's the best way to go about prescribing the combo therapy?
Yes. So our ultimate goal in combining short and long-acting agents is to provide kids with a steady level of nicotine in their system throughout the day with our long-acting agent. So when we think about taking all X thousand amount of puffs a day, those are just like peaks and valleys of exposure. And with a long-acting agent like a patch, we can provide a steady amount of nicotine in the system to hopefully decrease the amount of cravings or withdrawal symptoms they might have from those peaks and valleys of all of those puffs throughout the day. And then kind of like Kelsey mentioned, it's a reflex for patients just to have it in their hand and kind of have that muscle memory of putting something to their mouth. So our short-acting agents like a lozenge or gum or nasal spray can be used for those acute cravings or just that desire to just have something pick it up, all that muscle memory that they have. So just to reiterate, long-acting agent is our patch. Short-acting agents are our gum, lozenge, and nasal spray. And again, because there are so many different formulations, it's important to kind of have that shared clinical decision-making with your patient. Like, which agent do you think you could reasonably use and be adherent to? Because we know that the products work best when they're used consistently. So for example, like with the gum, we know it works best if patients chew at least 9 pieces a day, up to 24 pieces a day even. So just making sure like we get buy-in on what formulations we're going to prescribe so we know they're actually going to use it. And then once we've identified a combination therapy that a patient has agreed would be suitable for day-to-day life, as providers, making sure that we're prescribing the appropriate dosage. So depending on the product, dosing will be based on either how many cigarettes per day are used, which again is kind of that old prescribing based off of traditional cigarette use. So the patch, for instance, is dosed based on how many packs per day are used. And then again, we can do that equivalent-ish equation to figure that out for our e-cig users. Or the lozenge and gum dose is based off of how soon patients are using nicotine upon awakening. So making sure that we get the dosage right. And for a lot of these kids that might have like this high dependence, like we mentioned, we can't just add it on and have them keep using all of those puffs. So back to some of those like behavioral and plans to get them to cut back. We shouldn't be prescribing this if we don't think they're going to be able to cut back because like we mentioned, they're just going to feel sick. And then lastly, once the agents are identified, we need to make sure that we counsel adequately on use so that patients get the most effect. So the gum, for example, isn't just like your average bubble gum. You can't just pop it in and chew it and blow bubbles with it. You need to chew it, park it in your cheek, chew it, and it's a process that oftentimes isn't known to patients until we kind of have that conversation and counsel them through it. And then from a side effect standpoint too, like we love using the patch for that long-term relief, kind of giving patients heads up, like one side effect of the patch could be vivid dreams. That could be very alarming to a teenager that is just starting on their smoking cessation journey. So kind of setting that expectation ahead of time, like, hey, if this happens to you, take off your patch at night and just put it back on in the morning. That way, if that happens to them, they're not scared and stop using it altogether. They kind of have that advance notice just from an adherence standpoint is really helpful.
Use of the gum, I think that's going to be really important for providers to understand that chewing it and then parking it, against your cheek so that you get some absorption of the chemical. Because if you just chew it like regular gum, they're going to feel like, oh, this isn't working. And then they may just go back to using their vape.
Exactly. And I will say our institution's Partners for Kids has a really great prescribing guideline online that we could link to that kind of goes through each formulation, major counseling points, and kind of what, like a streamlined what to know about each agent, just because we want to make sure if we're prescribing this, it's going to work for our teens.
Yeah. And we'll put a link to that document that you're talking about. We also have some materials from the American Academy of Pediatrics in terms of nicotine replacement therapy and sort of best practices for prescribing those things. And those will all be in the show notes over at PediaCastCME.org. You mentioned that this is a long process. Is there such a thing as like rehab for nicotine, like an inpatient stay to maybe do it more quickly, or is that not really a thing?
I've never seen anything like that. And unfortunately, this is more of a kind of, for me at least, when I'm working with patients, it's just kind of, I warn them, this is not going to happen overnight. This is a long road. We're going to work together. And like Dr. JZ said earlier, I'm not going to abandon you if you return to use. So unlike other substances, there's not really like an inpatient rehabilitation program.
Okay. And then in terms of the other two medicines that you had mentioned, let's go through those, Kelsey. And if you could just let us know what their mechanism of action is, and then when we should consider using those things in addition or instead of nicotine replacement.
Yeah. Sure will. So, I think it's important to reiterate our first line or our first choice options when somebody is looking for nicotine cessation, especially in the adult world, are either that combination nicotine replacement therapy that we've covered or varenicline. Okay. Bupropion is considered a second line agent. So I'm going to talk about varenicline first. So varenicline is currently approved for patients 18 and older. And until that recent data that I mentioned before, we really didn't have evidence for people under 18. I am hopeful that as new evidence emerges, we'll be feeling more comfortable using it in younger ages, maybe down 16 and 17 years old. For now, that's kind of what we're doing right now. I'm not really starting varenicline yet in anybody under 18. But it has a lot of advantages if you do have a young adult who's 18 or older on using varenicline. First, I think convenience. So as we mentioned with nicotine replacement, it's something you have to actively do all day. So you put the patch on and then you're actively using the gum or the lozenge or the nasal spray pretty much the whole day. Whereas varenicline comes as an oral tablet. So you have to take it twice a day when you're at maintenance. So it makes it maybe a little bit easier. Another big advantage of varenicline is that you can have more of a flexible quit date. And what I mean by that is you don't have to stop vaping before you start varenicline. Okay. And that has to do with the mechanism of action, like you mentioned before. So whereas nicotine replacement is a full agonist at the nicotine receptor, varenicline is what's called a partial agonist. The way the partial agonist works is that it binds to the nicotinic receptor in a slightly different way than a full agonist would, but it is going to stimulate the receptor enough so that the patient shouldn't feel nicotine withdrawal. So we're stimulating the receptor to a lesser extent than a cigarette or a vape or a nicotine replacement would, but enough so that they don't feel bad. And the cool thing about partial agonists are that they act as a blocker or an antagonist when they're in the presence of a full agonist. So let me explain as an example. So if somebody is on Chantix or varenicline and they are taking their medication consistently, say they're in a really stressful situation and they decide to smoke a cigarette or they decide to use their vape. Since the varenicline is blocking the receptor and binding really tight to it, they really shouldn't get the effect that they did before from their vape because it can't find its target. So that's a really nice thing about varenicline because it allows people to set their own goals at their own pace and decrease their vaping or their cigarette use over time. So I think that's a big advantage, especially for young adults, to use varenicline. So when we talk about combining products, I will say since varenicline is going to kind of block that nicotine receptor, the data don't really show that there's a big advantage for adding nicotine replacement on top of it. So, for example, if you add a patch or you add gum or lozenge, pharmacologically, it doesn't make a lot of sense that it would provide additional benefit because the varenicline is blocking that receptor. But I will say anecdotally, it does help with hand-to-mouth physical dependence. So it's not going to harm somebody if you put a nicotine lozenge on top of their varenicline or gum, but if it helps them, like say they're going out with their friends and they always use their vape when they're going out with their friends and they just need something in that moment, I have given people gum or lozenges to put on top of their varenicline in those certain situations, just so they feel like they are able to do something in the moment and they don't reach for their vape. So that's an option. And there have been some studies with bupropion in combination with varenicline that may have some additional benefit.
And what does that medicine do?
Yeah. So bupropion is interesting, and many people have probably heard of it because it's also approved for depression. So we use it a lot, actually, in people under 18 for treatment of depression, but it also has an advantage of helping with smoking cessation. And the mechanism of bupropion, actually, it works on a couple neurotransmitters, dopamine and norepinephrine. So it is a reuptake inhibitor of norepinephrine and dopamine. And I think the idea is that, nicotine is so tied to that reward center and dopamine release that by having bupropion in there, kind of increasing levels of dopamine may help with smoking cessation if they're interested. So, like I said, this one doesn't have as great of data in terms of efficacy. It would be considered second line. But, it might be a compelling reason to use bupropion if you have somebody who is under 18 who has undiagnosed or untreated depression. It may help with that. And then consequently, it may also help with smoking cessation.
Yeah, it sounds like that one really focuses more on the physical aspect of, needing something in your mouth or, in terms of the antidepressant, anti-anxiety kind of effects that those medicines have, that maybe you don't feel that urge to have something in your mouth.
Yeah, kind of more of on a chemical level,
And then in terms of the varenicline, how do you wean that? Like, is that how that, like, do you just stay on it forever, or when do you know that you can start going down on that?
That's such a good question, Dr. Mike. And, working in the substance use space, we get this question a lot. And I think even for other medications that we use for substance use disorders, like when we look at opioid use disorder and we use buprenorphine a lot, people ask, well, when do you taper off? When do you taper off? When I first started in pharmacy, there was a thought of like, maybe you taper it off after 6 months or a year, or try to get them off as quickly as possible. I think like we, as a group of people helping folks with substance use disorders, we are now of the idea of as long as it's benefiting the patient, you continue it. So I kind of use that in nicotine cessation as well. If you look in the package inserts, it's going to say 12 weeks for all of these, but that is because the studies were only for 12 weeks. So I think it's really important to not view that as like an absolute. If I have somebody who's doing really well on Chantix and we get to the 3-month mark and they are not feeling super confident, I am not going to say, well, you have to stop it at 12 weeks. So that's really kind of, I think, where you work with the patient and continue the medicine as long as it's continuing to benefit them. If I were to taper off varenicline, what I might do is the maintenance dose is 1 milligram twice a day. It comes as 0.5 and 1 milligram tablets. I may try to go down to 0.5 twice a day for a while and then work down to 0.5 once a day and then wean off. I probably wouldn't just take everything off at once, just because I want the patient to feel confident at each step that they're going to be able to do it.
Another barrier to all of these things is going to be financial. So especially given that they're off-label use, do you find difficulty with insurance companies and Medicaid paying for these medicines?
Knock on wood, Dr. Mike, I've had a lot of success with getting these through insurance, especially our Medicaid managed care programs. They have been covered for, I can't think of any patients right now who haven't had it covered by a Medicaid managed care program. So I've really been happy about that and thankful for that. And so I say, if you have somebody who you want to prescribe, send a prescription, even if they're over 18, because a lot of insurance companies, even in the private sector, are covering these. They know that somebody with a long-term nicotine use disorder is going to cost them way more in the end than if we treat it right now. So I recommend always trying to write a prescription. Now, some other options, you can look, there's some pharmacy discount cards that might be able to be used that may bring the cost down a little bit. But if you're in Ohio, there's also the ability to receive free nicotine replacement therapy through the Ohio Tobacco Quit line, which is 1-800-QUIT-NOW. And you can call them, and I think they have a brief screener. And if you qualify, you can get nicotine replacement therapy at no cost. So I would also look into that if access was a big barrier.
Yeah, very, very good to know. Jen, what about you? I think we have mentioned this concept of harm reduction in the course of this episode. What exactly is harm reduction?
So harm reduction will be kind of the conversations and education we provide patients individually, kind of what we can provide to our communities to just raise awareness about what the harmful effects of nicotine can be and provide resources for cessation. Kind of like on a one-on-one level with patients, we talked about at the beginning, delaying use as much as possible. So kind of counseling patients and The American Academy of Pediatrics does recommend screening for nicotine use at every clinical encounter. So just having that conversation at every visit, even if it's not in clinic for nicotine use disorder. So our primary care providers, our hospitalists even can be screening just to kind of take inventory of, are you using? And if not, like
supporting
yeah,
in
yeah.
that and encouraging them in that decision to not use yet.
And then we talked about, too, reducing use as able. So harm reduction can be going from 10,000 puffs a week to 5,000 puffs a week. And it doesn't have to be that all or nothing mentality, just supporting patients through their different journeys. And I think the framework for this next one is important because we alluded to this earlier. Vaping is thought to be less harmful than our traditional combustible cigarettes from a chemical standpoint, and kind of the carcinogens we've known for decades are in traditional cigarettes. So it's important about how we frame it. We don't want to recommend e-cig use per se, but if we have a patient that's using traditional cigarettes and we can encourage them to switch to e-cigs, or, that can be one step in their journey. And that would also be considered harm reduction as well.
Yeah. And because we're not really endorsing full-blown use, we're endorsing a strategy for quitting being the end goal, recognizing it's not going to happen right this second.
Absolutely. And it's, like we said, could take months to years. And it's a process that takes a lot of support in clinic, out of clinic, at home, and just providing that education and having that rapport with patients, never being punitive, and just letting them know, we are here for your journey. If you return to use, is really important dialogue to have, while still being straightforward about the risks of nicotine use at all. So that messaging needs to stay consistent throughout any conversation you have with a teen.
Yeah, absolutely. Well, this has been really enlightening conversation, and I'm hopeful that it's also been helpful to providers who may be, it's important to get your teenage patients off of nicotine, but just not really understanding how best that you could do that. So hopefully we've raised awareness, and we'll put some resources. There's going to be lots of those resources in the show notes for you that we've been mentioning along the way, but particularly from the CDC and the American Academy of Pediatrics and then Nationwide Children's and Partners for Kids. Lots of stuff there for you. So be sure to check out the show notes over at PediaCastCME.org. And again, this is episode 109. You'll find all that stuff there for you. Before we go, Amy, can you tell us a little bit more about adolescent medicine at Nationwide Children's Hospital? You guys do lots more than just smoking cessation. What sort of services do you provide?
Yeah, we do a lot more than smoking cessation. I think we do provide primary care for adolescents and young adults. Adolescent programs across the country kind of do things all a little differently, but we do provide primary care. So well visits, vaccines, sports physicals, as well as care for chronic and acute conditions that come up. And then we also provide subspecialty care for adolescents and young adults. And so this does look like, obviously, substance use treatment and recovery, like we've been talking about. We have a nicotine cessation program. But we also provide eating disorder care. We provide gynecologic care for those with menstrual disorders. We provide sexual and gender health care, as well as reproductive health care. And then we also collaborate with a lot of different subspecialties in several different multidisciplinary clinics, which is some of my favorite parts about what we do. So we work with endocrinology, dermatology, sleep medicine, dietitian, and a PCOS clinic. We also work with hematology around patients with bleeding disorders and sickle cell. We just recently started working with rheumatology in their lupus and vasculitis clinic. Behavioral health we work with kind of throughout all of what we do, as well as developmental pediatrics and then pediatric and adolescent gynecology. And then lastly, we also provide care for our justice-involved youth at Franklin County Juvenile Intervention Center. So we definitely wear a lot of hats. But I think, as Jen and Kelsey have mentioned throughout all of this, is, substance use, smoking cessation can be talked about in a lot of these different realms as well. So it's a part of our everyday.
Yeah. And we'll put a link to adolescent medicine at Nationwide Children's Hospital also in the show notes so folks can discover more about all the different things that you guys do. So once again, Dr. Kelsey Schmuhl, Dr. Amy J.Z., and Dr. Jennifer Berg, thank you all so much for stopping by today.
Thanks, Dr. Mike. It was a pleasure.
Yeah, thank you so much for having us.
Yeah, we appreciate it.
are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks again to our guests this week, Dr. Kelsey Schmuhl, Dr. Jennifer Berg, both patient care pharmacists at Nationwide Children's Hospital, and Dr. Amy Jay-Z, Adolescent Medicine Fellow, also at Nationwide Children's. Don't forget, you can find our podcast wherever podcasts are found. We're in the Apple Podcast app, Spotify, iHeartRadio, Amazon Music, Audible, YouTube, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, our CME information, the terms of use agreement, and the handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, LinkedIn, X, and Blue Sky. Simply search for PediaCast. So you have listened to the podcast. Now be sure to claim your free Category 1 CME credit. Really easy to do. Just head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, click on the Materials tab, and take and pass the post-test, and the free Category 1 credit is yours. Super easy, right? And again, we offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We also have an evidence-based podcast for moms and dads. It's called PediaCast, very similar to this program. Lots of pediatricians and other medical providers also tune in as we cover pediatric news and interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org, also available wherever podcasts are found. Simply search for PediaCast. An additional podcast that I host is called Pharmacist. This is a faculty development podcast from the Center for Faculty Advancement, Mentoring, and Engagement at The Ohio State University College of Medicine. So if you are a teacher in academic medicine or a faculty member in any of the health sciences, then this is a podcast for you. You can find Pharmacist at pharmacist.org and wherever podcasts are found by searching for Pharmacist. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.